Assalamu alaikum. Today we are going to present a seminar about tuberculosis presented by me, Fatima Mohammed, and my colleague Haneen Basem Mohammed, supervised by Dr. Elaf Abdulwahhab. Introduction. What is tuberculosis? Tuberculosis is a communicable chronic granulomatous disease and major health problem in the world. Tuberculosis, also called TB, it is an infectious bacterial disease caused by Mycobacterium tuberculosis, which most commonly affects the lung. It is usually transmitted from person to person via droplet from throat and lung of people with the active respiratory disease. TB in the past was known as consumption because of the pronounced weight loss that it caused. Other common names include wasting disease and the white plague. Epidemiology. WHO considers tuberculosis to be the most common cause of death resulting from a single infectious agent because it is estimated that around 1.7 million individuals are infected worldwide, 8 to 10 million new cases, and 1.5 new deaths per year. Tuberculosis thrives under conditions of poverty, crowding, and chronic debilitating disease. Also, there are certain disease states that increase the risk, such as diabetes mellitus, Hodgkin lymphoma, chronic lung disease, particularly silicosis, chronic renal failure, malnutrition, and immunosuppression. In areas of the world where HIV infection is prevalent, HIV infection is the dominant risk factor for the development of tuberculosis. Etiology, or what are the causative agents of TB? Pulmonary tuberculosis is primarily caused by Mycobacterium tuberculosis, while Mycobacterium bovis is mainly responsible for oropharyngeal and intestinal tuberculosis. Also, there is Mycobacterium avium complex, which causes lung disease in immunocompromised patients mainly. Most cases of active TB result from activation of a latent TB. This picture showing the microscopic appearance of the TB bacilli. The characteristics of Mycobacterium tuberculosis. First, it is impermeable to the gram stain, not stained by the usual gram stain, because it has a waxy cell wall rich in lipid and mycoric acid, which make them acid and alcohol fast. Therefore, these acid-fast bacilli are stained by Ziehl-Neelsen stain. This picture showing the microscopic appearance of the TB bacilli, these red roots stained by Ziehl-Neelsen stain. How tuberculosis is transmitted? Nearly all TB infection acquired by inhalation of respiratory droplets from people with TB. Less frequently, it is transmitted by ingestion of Mycobacterium bovis in unpasteurized milk product, inoculation in skin tuberculosis, transplacental route, and laboratory accident. Things that increase the probability of infection. Greater the time spent with infected person, when the concentration of the TB bacilli circulating in the air is greater, poor ventilation, and poor sunlight. Types of tuberculosis. As we have said before, lung is the main organ affected in TB. Therefore, tuberculosis is mainly divided into pulmonary and extrapulmonary. And depending upon the type of tissue response and age, the infection with the tubercle bacilli is of many types, including primary TB, progressive primary TB, secondary TB, progressive secondary TB, and miliary TB. Primary tuberculosis. It means infection of individuals who have not been previously infected or immunized. It is also called primary complex or gone complex. Grossly, it appears as a small tan yellow subpleural lesion in the mid-lung zone. That extends to the hilar lymph node. This yellow tan granuloma in the hilar lymph node next to the bronchus. These two are called the primary complex or gone complex. While microscopically, it consists of granuloma with gaseous necrosis. Here, is the gaseous necrosis, this amorphous pinkish material surrounded by epithelioid macrophages and there is peripheral rim of lymphocyte. The fate of primary tuberculosis. Most of the cases, around 95%, heal by fibrosis. Some may enter into dormant state and few many may spread, forming progressive primary TB. Secondary tuberculosis. It means that infection of individuals who have been previously infected or sensitized. It also called post-primary TB. The infection may be of endogenous source, such as reactivation of dormant primary complex, that is to say, reactivation of the Mycobacterium bacilli, or exogenous source, such as a fresh dose of reinfection by tubercle bacilli. The microscopic and macroscopic appearance. Grossly, it may affect the lung, the apex of the lung in particular, with minimal lymph node involvement. There is multiple granuloma in the apex of the lung, and there is damage to the parenchyma of the lung with cavity formation. Microscopically, same as in primary TB, granuloma with gaseous necrosis. This is the gaseation surrounded by epithelioid macrophages and peripheral rim of lymphocyte. Here we can see some giant cell, Langerhans giant cell. This. The fates of secondary TB. Heal by fibrosis or may spread, forming progressive secondary TB. Miliary tuberculosis. It is caused by hematogenous dissemination of TB bacilli with widespread involvement of multiple organs due to depressed immunity of the patient. يعني يحصل الملياري تي بي mainly بالimmunocompromised patient مثل HIV infected person, children, elderly, and people on corticosteroid therapy. And in miliary TB, the TB bacilli invade the blood. Grossly, miliary TB appear as a small discrete nodule 1 to 2 mm in diameter, evenly distributed throughout the lung. This is small nodule, yellow to tiny granuloma, evenly distributed throughout the lung. This picture showing the miliary TB of the spleen. In the cut surface, there is multiple yellow to tan or grayish to white small nodule representing the granuloma, thus miliary TB. After we have finished pulmonary tuberculosis, we will talk a few points about extrapulmonary tuberculosis. Also, it occurs in tissues or organs seeded hematogenously. Common involved organs include, as we can see in this picture, neck lymph node known as scrofula, CNS causing tuberculous meningitis, in the adrenal gland causing adrenal TB, which then lead to Addison disease, in kidney causing renal tuberculosis, in bone and joint is caused Putz disease. It may go to the fallopian tube causing salpingitis, which then lead to infertility. Also, in the recirculation of the blood, TB bacilli may go again to the lung and causing biliary TB of the lung.
Assalamu alaikum wa rahmatullah. I am Haneen Basem. I will continue the second part of our seminar and I start with pathogenesis and the step for granuloma formation. In first exposure, the myobacterium successfully reached the alveoli close to the pleura, where we have macrophage which will phagocyte them, leading to formation of phagosome. The myobacteria is inside the macrophage. It will inhibit the fusion between the lysosome and the phagosome. Then the myobacterium will proliferate within the alveolar macrophage and airspace to cause a localized infection. 3 weeks after this infection, the cell-mediated immunity will start. It is type 4 hypersensitivity and the granuloma will be formed. Some of macrophage go to the draining lymph node and present the myobacterium tuberculosis to CD4 T cell, which will release cytokine. This cytokine will attract and activate macrophage, leading to formation of epithelioid cell, help in the development of cytotoxic T cell, which can kill tuberculosis infected macrophage. Activated macrophage and cytotoxic T cell will lead to the destruction and necrosis of lung tissue infected with myobacterium tuberculosis. This is steep leading to formation of granuloma. After that, the granuloma will enlarge, leading to formation of what is called confocus, which has central granular creamy cheese-like gaseous necrosis. This picture shows the microscopical appearance of a granuloma with gaseous necrosis in patient with primary tuberculosis. In the center, we see a gaseous necrosis surrounded by epithelioid macrophage and then surrounded by a rim of lymphocyte. This picture shows the cross appearance of lung in patient with primary tuberculosis and has large central area of gaseous necrosis and white yellow tan debris. After that, the tubercle bacilli travel to the regional lymph node, either free or within the phagocyte, and cause caseation, and this is called cone complex. This picture shows the lung in patient with primary tuberculosis and has cone complex. In about 95% of cases, development of cell-mediated immunity might control the infection. The bacteria will remain in a latent state. The bacteria could be latent for years within the granuloma. The granuloma then undergo fibrosis and calcification, producing scar tissue that can be seen on X-ray. This is called ring complex. This picture shows the X-ray in patient with primary tuberculosis, and the granuloma has V calcification, S calcification, and formation of ring complex. Until this point, this is called primary tuberculosis. In immune-compromised patients, as in patients with acquired immune deficiency disease or in impairment of host defense mechanism or in malnutrition children or in the elderly, they may develop to progressive primary tuberculosis without going in a latent state, which lead to formation of tuberculosis meningitis and biliary tuberculosis. This picture shows an inflammatory reaction in patient with immune-compromised and has a progressive primary tuberculosis and has center gaseous necrosis. On second exposure to the Mycobacterium tuberculosis or reinfection, or if the immune system is compromised, as in acquired immune deficiency disease or aging, the gun focus will be reactivated and the infection will spread to one or both upper lobe of the lung. Since this is the second exposure, the body will respond vigorously to all of the focus. T cell will release cytokine, which will lead to more area of gaseous necrosis and cavitation. The cavity will allow the bacteria to disseminate through the airway or lymphatic channel to other part of the lung, leading to the development of bronchopneumonia, or is disseminated through the vascular system and infect almost any other part of the body, leading to systemic biliary tuberculosis. This picture shows the cross appearance of lung in patient with secondary tuberculosis and has a large area of central necrosis and has an area of cavitation. We see the cavitation here. This diagram shows a simple review of pathogenesis of tuberculosis. After inhalation of Mycobacterium tuberculosis and phagocytosis of bacilli, alveolar macrophage is first cell affected by tuberculosis. It starts to secrete interleukin 12 and interleukin 18. This interleukin causes T cell activation, so CD4 T cell and CD8 T cell is activated. It starts to secrete interferon gamma. This interferon is induced bacterial killing. After that, tissue necrotic factor alpha secreted primarily by alveolar macrophage and then by T cell. This factor is important to control of mycobacterium growth and the granuloma formation. The control of mycobacterium growth is by a stop of mycobacterium proliferation and the chronic cytokine stimulation. After that, the granuloma is formed. It's formed by several cells recruited into the lung. The alveolar macrophage containing Mycobacterium tuberculosis preventing their separate. Post-primary tuberculosis occurs when Mycobacterium is associated with failure to immune system, or disease may reactivate, or damage of nearby bronchi, or spreading of Mycobacterium tuberculosis to other area of the lung. This diagram shows the fate of Mycobacterium tuberculosis after inhalation. After inhalation of Mycobacterium tuberculosis, it is reached the lung and enter the alveoli, and the tuberculosis lesion occur. In about 90 to 95% of the patient, the Mycobacterium tuberculosis spread by hematogenous spread. So Mycobacterium tuberculosis DNA detected in tissue by PCR. or about in 5 to 8% of infected person, its progression to cavity tuberculosis or the cavity tuberculosis occur where the activation of tuberculosis happened, for example, after immune suppression in human immune virus infection or in smoker. The cavity is opened into the bronchi, allowing spread of Mycobacterium tuberculosis through coughing. Sign and symptom of tuberculosis. A classical clinical feature associated with active pulmonary tuberculosis are cough, it's a productive cough, weight loss, anorexia, fever, it's low-grade fever, night sweat, hemoptysis in advanced state, chest pain, fatigue. Symptom of extrapulmonary tuberculosis. It depends on the organ affected by tuberculosis. For example, if we have central nervous system affected, the symptoms are confusion, coma, neurological defect, chorioretinitis, lymphadenopathy, cutaneous lesion. Diagnosis. We take medical history, we do physical examination, we do microbiological tests, we have a bacteriological test, Zell-Nelson stain, Uramin stain, fluorescence microscopy, and sputum culture test. Lewin stain Jensen solid medium, it take 4 to 18 weeks. Liquid medium, it take 8 to 14 days. Agar medium, it takes 7 to 14 days. Radiography, chest X-ray, nucleic acid amplification, and tuberculin skin test, injection of a purified protein derivative into the skin of lower arm. 48 to 72 hours, check for a reaction. Diagnosis is based on the size of the well. The one dose contain 0.0 millim and contain zero point 0.0 microgram of tuberculin. This state doesn't differentiate between previous or active infection. Vaccination, Bacillus calmette-guerin (BCG) vaccine, given to protect neonates as injection of attenuated tuberculosis bacilli. It is contraindicated in immune-compromised patients like acquired immune deficiency disease. And thank you.